All right. Welcome, everybody, to Cardiovascular Medicine Grand Rounds. It is an honor to introduce today's speaker. Dr. Robert Hawkins is an assistant professor in the Department of Cardiac Surgery at the University of Michigan. He was raised in Connecticut and Virginia before completing his undergrad studies in neurosciences in Middleburg College in Vermont. He then received his medical degree from the University of Colorado, where he also received multiple awards, including the Best Surgical Student. He completed his thoracic surgical residency at the University of Virginia in Charlottesville, where he also spent 2 years performing basic science research with Dr. Alawati, examining the mechanisms of thoracic aortic aneurysm development. In addition, he obtained a master's in clinical research from the University of Virginia and helped grow the Health Service Research Program. Dr. Hawkins' current clinical research focuses on the impact of health policy, economics, and disparities on cardiac surgical access and quality. His clinical research spans cardiac surgery disciplines, including revascularization, valve replacement, mechanical circulatory support, and transplantation. His basic science research focuses on the microRNA pathways of thoracic aortic aneurysm formation. He has published over 150 peer-reviewed manuscripts, over 30 invited editorials, and he reviews for multiple journals. He's also the associate statistical editor of the Journal of Thoracic and Cardiovascular Surgery. Dr. Hawkins' clinical interests relies on complex coronary revascularization, where he also helps lead a multidisciplinary team to provide patients with personalized revascularization strategies. He performed both transcatheter and surgical aortic valve replacement, and he has an interest in heart failure and optimizing surgical approaches for these often high-risk patients. He will be talking today about multi-arterial grafting, evidence, controversies, and disparities. Welcome, Robert.
All right, so let's just make sure. So very briefly, we'll be going over sort of definitions, technique aspects of multi-arterial grafting. We'll go over the evidence, the controversies, and then the disparities. I have probably too many slides, so if I'm rushing and you have questions, just interrupt. And happy to talk about anything in more detail if you have questions. So for CABG, there are a whole host of variables that go into how we do it that essentially creates an individual operation for every patient. You can change your approach. You can change the circulatory assist that you provide, the conduits you use, and then how you use them with inflow and outflow. So approach. So this is, the standard is a sternotomy. 99% of patients in the United States get a sternotomy. Some redos in other complex cases can get a thoracotomy. And more recently, there's been a resurgence of robotics in this arena. About 2 people are doing totally endoscopic robotic CABG, but robot-assisted CABG is on the rise. The circulatory assist, so we also use cardiopulmonary bypass. But you can also not use cardiopulmonary bypass. You can arrest the heart. You cannot arrest the heart. All of these are possibilities that allow for a safe approach to doing these bypasses in patients who have different burdens of atherosclerosis in the aorta, within the coronaries, and you can sort of customize how much support you're giving. The conduit. So the backbone of CABG is the left internal mammary and saphenous veins. That accounts for about 85 to 90% of bypass surgery in the United States. But you also have great options with the right internal mammary artery, the radial artery, left and right, gastroepiploic, basilic vein. You can start getting really crazy with all sorts of alternative options. But the farther down you get, the less it's used and the less high quality it is. Then the next question is inflow and outflow. So Do you leave your IMAs in situ? Do you take them free? Do you splice them? Do you do an eye graft where you can extend the rima with a radial? The opportunities are essentially endless. And so all of these different configurations have potential benefits, but also downsides depending on the coronary disease anatomy. That's not really the purpose of the talk, but you can see how different conduit options can lead to more CABG options for patients with complex disease. So let's go way back into the 80s. What we started with is a whole bunch of publications that really started identifying that vein grafts maybe weren't doing that great. So this study looked at 132 grafts that were patent at 1 year and where the patients were alive at 10 years. So we're already biased, right? These are like patients who are doing well with open grafts. So we've already excluded all the patients who didn't do well. Only 38% of those grafts didn't have disease at 10 years. That was followed up by Loop with the seminal paper in the New England Journal of Medicine that demonstrated improved 10-year survival, MI, readmissions, reoperations, late cardiac events, all of it when you used a lima to the LAD instead of all veins. This was a retrospective study, but it was a seminal paper in the New England Journal of Medicine, 1986. That was soon followed up in 96 with Cameron using the CAS registry, so the coronary artery surgery study. And there were about 5,000 patients who had all vein CABG, and there were about 700 patients who had a lima LAD. So you can still see, even by 1996, this is a minority of patients who are getting a lima to LAD, and there was a dramatic reduction in 15-year mortality associated with the use of the lima. So now you see a growing interest in single arterial grafting, both based on patency and survival. So now we start to study it with randomized trials looking specifically at patency. So the VA has been an important component of these trials in a variety of different studies, but this was the first one, the first VA cooperative study program analysis, where they randomized patients, so they're all male, and they either had a vein graft or a lima, and then they looked at the long-term patency. So angiography was performed at year 3 and 10, or as clinically indicated, and the 10-year vein graft patency was dramatically lower. Now, this study actually didn't have particularly good graft patency outcomes. As you can see, it's not really what we discuss with patients in terms of the lima, but it wasn't always done to the LAD. And what we find is the more selective you get, the better that graft patency gets on the arterial side. On the vein graft side, that's not entirely true. Now, we do know that the LAD has the best patency of all the targets. It tends to be large. It tends to have tight proximal disease. And the results are just not the same on the left and the right. So almost all of this seems to come down to graft patency. So what is the difference? Well, what we see is that there are 3 vein graft failure modes. There's early failure, which is technical. That includes Harvest trauma, anastomotic errors, strictures, problems with your anastomosis. That affects every single anastomosis that we do. It's not limited to vein grafts, but they're also more likely to be diseased or have thrombosis. Then midterm, 1 to sort of 2 years, there's intimal hyperplasia, and that also affects a fair number of grafts. And that is about sort of 1 to 2% failure rate per year from intimal hyperplasia. And then the long-term problems are atherosclerosis. So about a 5% per year graft failure rate, and that affects every single vein graft. So when we see that veins are bad and one arterial graft is good, the obvious question is more better? In 2001, there was a meta-analysis that looked at specifically BEMA versus a single IMA. This was by Taggart, and they identified a whole host of retrospective analyses looking at this topic. There were not any randomized trials available. And what we can see is that there's a 20% survival advantage to BEMA. That is very significant. That prompted the ART trial, the arterial revascularization trial, Taggart as PI, and they randomized patients to single or bilateral internal mammary arteries. At 5 years of follow-up, the rate of death was only 8.7% in the bilateral group and 8.4% in the single group. So there was no difference. But those outcomes are excellent. What we can see is a very flat curve. So if you really zoom in, you can see that there's largely no difference. When we look at all the composite, death, myocardial, or stroke at 5 years, also no difference. Maybe you start to see some lower rates, but it's not statistically significant. And again, this curve is very flat. Overall, the rate of MACE was only 12% in both groups. What did come out of this trial was that there is an increased risk of sternal wound infection for the BEMA patients. So it was 1.9% versus 0.6% in the trial. When we look at the 10-year results, there was still no difference. So this is a negative study. But why? Why was ART negative when the other data seemed so promising? This was one of the first really large-scale multinational sort of surgical trials to demonstrate some of the real big issues with running these complex trials. There was huge protocol deviations. There was about 13.9% of patients in the single internal mammary artery group, they got a radial. So they completely crossed over. Then 21% of the patients also crossed over in the other direction. So the intent to treat was a complete pointless analysis. But it also, there are people who got PCI instead of surgery. They canceled, they withdrew. So the protocol deviations in this trial were probably the most important learning aspect rather than the outcomes. The alternative is that maybe there is no difference. So there continued to be a number of true believers that kept thinking that multiple arterial grafting was better. And so attention was turned to the radial artery. Radial artery use was really low for a long time, related to concerns of vasospasm due to the muscular nature of the conduit. However, there's evidence that that can remodel after grafting, and it can develop an elastomuscular profile, and thus probably lacks the need for long-term antispasmodic therapy. In fact, there's now even evidence that radial grafts that have early spasmodic failure from competitive flow and show a string sign early can even recannulate later. Now, there have only been a few small randomized controlled trials looking at the radial artery as a second arterial conduit. All of them are about 200 patients or less. And so a patient-level meta-analysis was completed in 2018 by Mario Gaudino, published in the New England Journal. It included a grand total of 1,000 patients, and they found better graft patency. Just like every other study that we have talked about, the radial artery is a better conduit than the saphenous vein. They also did find that there was so that hazard ratio was 0.44 for graft occlusion. Sorry, I keep clicking instead of moving the arrows. The composite was significantly better with the radial artery, but that was really driven by repeat revascularization. Again, graft patency. The composite had no difference in death And then MI was marginally better. It really barely statistically significant. It was driven by repeat revascularization. So where do we stand now? And that really is almost all of the evidence, by the way. Surgeons really consider both the radial and the REMA excellent options. But many surgeons do not believe the multiple arterial grafting data in terms of improved outcomes. You can see over time in the Society of Thoracic Surgeons database, there's been up and downs, but there's not been a giant spike in adoption. It has roughly been in the 8 to 12% range for the majority of time analyzed. There are also a whole bunch of nuanced differences. The REMA is best in situ, which means it is short. There are a whole bunch of things that you need to do to mitigate wound infection risks. For the radial, there's a whole bunch of competitive flow and coronary anatomy considerations you need to consider. And then you also need to evaluate the palmar arch, the conduit itself, calcifications, and whether there's been injury to it in the past, either trauma from the patient, trauma from prior caths. And so given that there are still a number of true believers to multiple arterial grafting, we've returned our attention back to retrospective analyses, back where we started with the original Lima versus vein graft study. The STS recently published a large retrospective analysis where they linked over 100,000 patients to CMS data for long-term survival. This was a really good study because most of the other studies in the retrospective analysis phase, you either get STS data, which is 30 days, or CMS, which has no clinical risk adjustment. They finally were able to really do a good job, pull it together, and there is a clear divergence between the curves. Multiple arterial grafting has better survival at almost every time point after 2 years, and the curves keep diverging. There are certain subgroups they found where this wasn't true, and it's probably what everyone in this room would expect. Patients who don't have the same long-term survival expectations as young, healthy patients do. So patients over 80, patients with severe chronic kidney disease, peripheral arterial disease, bad heart failure, all of those patients did not have the same survival benefit to multiple arterial grafting. What was interesting was there was only one group where it was actually potentially harmful, and that was BMI over 40. We talked about the wound infection risks associated with BEMA, but it didn't really matter whether you used a REMA or a radial. And so it's not fully understood where that data is coming from. But these hearts have more diastolic dysfunction. There might be more incomplete revascularization associated with trying to do multiple arterial grafting in really thick hearts that you can't access the posterior wall for and are that deep. And so really, that's a subgroup of patients that needs more study. But this is still retrospective. And so right now, the effort is in the Roma trial. About 4,300 patients were enrolled, randomized 1-to-1, multiple arterial grafting, single arterial grafting. The 5-year follow-up is pending. In our state, we believe the data. As a whole, our society, our Quality Improvement Society, believes that the evidence points that multiple arterial grafting is probably better. There's no clear evidence for survival in randomized trials, but we know the grafts are better. We know they last longer. There's probably reduced repeat revascularization, probably reduced MI, and hopefully in well-selected patients, that leads to survival advantage. So what we've done is increase the rate. And as a state, we have one of the best quality improvement collaboratives in the country. And well, I think we can safely say I think it's the best. And we've made a big difference. We've gone from 11% to 36%. And in the last year, we don't have any definitive numbers, but the rates are even higher. The society goal for MAG, I think, is over 40%. But what we're seeing in our state is that there are really surgeon-based trends. There are a certain number of people who do not believe the data and refuse to go on board. The operations are longer. The complexity is more. And they say, I can do a really good job with vein grafts, and I'm going to stick with that. Then there are surgeons that have a very high use of the radial artery and almost no BEMA use. And then there are the BEMA users. Very few surgeons in the state use everything. Very few surgeons do total arterial, and very few surgeons in the same patient use both the REMA and the radial. So let's move on to the controversies. So to be honest, there aren't a ton, but one of the aspects of recent guidelines is that there's been some grumbling from the surgical societies about a variety of changes in the class of recommendations for different aspects of CABG. As it relates to multiple arterial grafting, there are sort of three main things to focus on. One, Lima to LAD is a class 1 recommendation. No change, no argument. The data is very clear. What's interesting is that radial as a second conduit was also upgraded to a class 1 recommendation. There are no qualifiers, and it's the same as Lima LAD. We've just shown that the patency is probably not the same on other territories. We've just shown that there are no randomized studies saying that this has a survival advantage. There's no qualifiers or no admittance of differences in the level of evidence out there related to these two differences out there. It's particularly interesting because you then look at the REMA, and the REMA is a 2A, lower class of recommendation, and it has qualifiers. Only experienced surgeons should use the REMA. Only in appropriate patients. The one study that they used to justify that was from 2018 that showed that here you can see for the radial, this is less than 5% of CABGs using the radial artery, increased risk, but then it's all about the same. Here you can see that in beta use, there's not really a clear volume relationship. So I personally don't understand this at all. If there's any volume relationship from this study, it's in the radial. The concern really should be that the beta use doesn't improve mortality in the same way that the radial does. But that's not what's in the guidelines. Because of that concern, this study was also just updated. And what we see is that if you're doing less than 10 with beta, your O to E for mortality might be a little bit high, but it's not statistically significant. And then it goes down from there. So there is probably a little bit of a volume relationship, but none of it for mortality is statistically significant. There is some morbidity, largely driven by wound infection and other complications. Here for the radial artery, there seems to be more of a trend. Low radial artery use cases or hospitals have high O to E, 1.67 when they use the radial artery, and that cuts down to less than 1 for high use hospitals, so greater than 30 radial artery cases per year. Does not match the guidelines. So thinking more about this, there's clearly differences. Yes. So we are a relatively low volume CABG hospital, but when we look at this, we are in the moderate to high. I don't know year over year if we consistently are greater than 30 in each of those categories, because we have surgeons that do both. So we have high radial users and high REMA users. And so we are always over 10 in both of those categories. In some years, we may also fall into the high use. So a lot of the controversy here also extends into the surgeon's sphere of how we argue over these conduits and why certain surgeons are radial users versus REMA users. A lot of folks are very focused on infection, and the impact that the REMA has on that. You do have to select your patients carefully. If the A1C is 12 and the BMI is 40, that is not a very good BEMA case. However, the majority of patients in that category probably aren't going to be in the healthiest group that would benefit most from it anyways. And so the other aspect of that is that you can reduce the risk potentially by skeletonizing the REMA. That in and of itself is controversial. There are a whole host of papers that argue over skeletonizing versus taking as a pedicle the IMAs, meaning the fascia and the veins in a pedicle, or taking all of that off and just taking the artery. The pedicle is sort of the standard for most teaching institutions. It's easier to do. There's less risk to the artery, but you devascularize from a vein perspective the whole chest wall as well. And so if you skeletonize, you may be able to reduce the risk of infection, but you may increase the injury, noticed or unnoticed, and reduce the patency of those grafts. For radial, there's a whole host of variation in care practices related to how you assess the radial before a surgery. There are conservative institutions, which we have traditionally been, where you measure and map the palmar arch with compression studies, have certain thresholds for what pressures drop in the thumb to allow for safe harvesting of the radial, whereas others do a quick Allen's test, and if it's okay, say you're good to go. So what you see is high radial use surgeons have less strict preoperative assessments, therefore more liberal acceptable use cases for the radial artery. There's also a big push for cathing radial, and different cardiologists have different preferences for how that's done. A number of times with outside referrals, you see right-handed patients with left-sided caths and vice versa. Here we tend to cath from the right, but I have a whole host of patients who are left-handed. And then you get into all sorts of discussions with patients and patient preference about whether you want a potential risk associated with your dominant hand. So the nuances for how you use the radial, all of these have competing problems, right? We have a push for cathing radial, but then we also have a push for using the radial during CABG. We have a push to decrease our sternal wound infection rate. We have a push to increase our use of the REMA. All of these are trade-offs. Then finally, there is how you actually think through the revascularization itself and use of the conduits. So we talked a bit before about how you can use different inflow and outflow with all of the different conduits. You can do single inflow to outflow. So that's sort of the traditional way that CABG is done, whether it's an in situ lima to a single distal on the LAD, and then vein graft, aorta to PDA, aorta to OM. That's sort of the standard way that's most often done. But you can then start doing Ys off of the conduits. You can extend them, you can do sequences, and you can combine all of those things. But what is clear is that vein graft failure modes all relate to the intima itself, intimal hyperplasia and atherosclerosis, not competitive flow. So the amount of flow above a certain threshold is not going to influence your vein graft outcomes, meaning if it's an intermediate risk or an intermediate severity lesion, that is fine, just like a critical lesion. It doesn't matter. You don't have to think as much about your bypass grafts if you're doing veins. If you think it's disease, just put a vein on it. That's not true for arterial grafts. For the IMAs, you have to think about in situ Y, and then whether it'll reach. You have to be able to look at CT scans and caths and estimate length and really plan for how you're going to complete that procedure in a safe way that is tension-free. And then if you're wrong, you have to be able to pivot in that operation with the arterial graft, and that adds complexity and time to the operation. So Sometimes those remas, which were planned to be in situ, become free. You have to splice them to get them onto the aorta, or you wire them onto one of your other conduits. Being facile with that is a rare skill in cardiac surgery. Very few surgeons are able to pivot mid-procedure and change the configuration of their grafts in a way that doesn't change the flow dynamics. So as soon as you start wiring off, you now have flow going in different directions. And the resistance of the vascular bed can impact whether or not those grafts stay open. There's a ton of evidence coming out now that we are using flow measurements as to how to predict graft patency based on the stenosis, proximal stenosis, so competitive flow, and distal disease or ability for outflow to predict patency. It seems like the IMA is not as susceptible to competitive flow as the radial artery, as it's not as muscular and it has a very nice elastomeric wall that emits lots of nitric oxide and is not susceptible to atherosclerosis, but it doesn't have the reactive muscular bed as well. And so using those on intermediate lesions is probably more acceptable than the radial. There's also been a big push for functional assessment of intermediate lesions. Now that's mostly driven by PCI outcomes and only stenting important lesions in order to derive the benefit without the risks of PCI. But we've been trying to translate that to CABG. Everything we just talked about in terms of veins means that FFR is not helpful if you are going to bypass that artery with a vein. Really, if it's 50, 60% vein graft is not going to differ in patency, whether the FFR is 0.89 or 0.04. You know, that is not going to differentiate vein graft patency. However, we are trying to figure out what are the different thresholds that may impact arterial graft patency. Different surgeons have found different things. So in this algorithm, you can see how complicated it gets. The big point being, if there's an intermediate risk, intermediate degree of stenosis on the circumflex territory, it might be worth doing a functional assessment if you think the patient could benefit from an arterial graft in that territory. If you find that it's not ischemic, that is helpful. We might still put a vein to it. If you find that it is severely ischemic, we can put anything to it. That's great. We don't quite yet know what to do with those intermediate range. This uses an FFR threshold of 0.78. A lot of surgeons are saying 0.7 for the radial artery on an OM. We don't really know, but the lower that number gets, the safer it is to assume that a radial artery will have good patency. It can be very informative for the intermediate risk or immediate severity lesions. So we just talked about whole disparity of evidence, differs whether it's retrospective, prospective, REMA, radial, crossover. It's very confusing. We also talked about how surgeons have very set preferences, REMA, radial. And we also talked about how there's a variety of risk factors that can influence those decisions. All of those things are going to vary by hospital, the patients, the surgeons, and that has been leading to a wide variation in use of multi-arterial grafting across the country. Not just by state, but by zip code. Hospitals across the street can have completely different multi-arterial grafting rates. When we look at our state, we also see very different multi-arterial grafting rates. The numbers on the far left are the total CABG volume for that institution. So isolated CABG, nothing else. No valves, no complex ablations, things like that. This is just CABG. And it's CABG with at least 2 grafts. what you see is that the rate of multi-arterial grafting varies between 0 and almost 70%. That is huge variation. What you also see is it's not necessarily volume dependent. You can see some very high volume centers, 600 cabbages, 13% multi-arterial grafting rate. Very low volume centers, 71 cabbages. About 80 of them, or 80% of 70% of them were multi-arterial grafting. It is not a volume outcome relationship when it comes to the use. That amount of variation means that you're also going to find disparities in application of the method. We recently looked at female patients. They're known to be different. A female cabbage is not the same as a male cabbage. They tend to be higher risk. They present with more comorbidities, tend to have lower ejection fraction, more diastolic dysfunction. They have smaller vessels. These are more difficult cases. It has been known that they have lower multi-arterial grafting rates across the country. The SDS has shown that. But here in Michigan, we wanted to improve multi-arterial grafting rates for everybody. So we thought that we would be closing the gap with our quality improvement initiative. Turns out the opposite is true. Surgeons were going for the low-hanging fruit. We wanted super high multi-arterial grafting rates. Well, men make up the majority of cabbage, about 2/3 of actual cabbage cases, and they're easier. So they actually had more increase in multi-arterial grafting use than female patients. Here you can see those trends over almost a decade. Women consistently lower than men for REMA, radial, overall. What's interesting is that as of even 2019, there was a lower LEMA use in women than men. Now in Michigan, that quality improvement initiative happened, I think, a decade ago. And there's no disparity in LEMA use in our state, but that took conscious effort. Clearly, these cases are not the same if the gold standard, LEMA to LAD, has a difference between patient sex. Those disparities in use also beg the question of why and the impact. Are the fundamental differences leading to differences in use of multi-arterial grafting also impacting the outcome? So if you do multi-arterial grafting, the survival advantage we see in men, is that the same in women? Or are the difficulties that lead to surgeons not wanting to do it also leading to inferior multi-arterial grafting outcomes? This is a New York State analysis where they took about 50,000 patients and stratified them by patient sex. And here you can see sort of a standard multi-arterial grafting versus single arterial grafting curve where we see them diverging. And they continue diverging the longer you get into the follow-up. That's not true for women. They found almost no difference. It may have separated it at the beginning, but by the end, those curves come together. Then there was just a paper out from Australia and New Zealand, and they did not find the same thing. They found no interaction term difference between patient sex. So the curves you see, you might say, oh, maybe the one on the right, which is women, is slightly closer together. But statistically, there's no difference between these curves. Men and women had similar survival benefit with multi-arterial grafting. This has essentially led to complete uncertainty as to the answer. We know that women make up fewer cabbage patients. We know that they make up even smaller numbers of clinical trial patients. None of the clinical trials that we have sufficient power to analyze women as a subgroup. The Roma trial won't, our trial didn't, and certainly none of the small radial trials have any sufficient number of women to separate them out with enough power to determine if there are any differences. The result has been a spinoff of the Roma trial that looks at women only. So currently we are enrolling in Roma women, and it takes just those patients, which has been repeatedly said to be an impossible trial to enroll in, and it is actually enrolling. So if you have any patients that you think might be a benefit to this and could inform our understanding, we would like to improve our enrollment in this trial. It's an important question, and we really do not know the answer to this. We also looked at differences by socioeconomic status. Now, there are a whole host of issues, difficulties with analyzing surgical outcomes in this way. That can be discussed later. But what we use here is the Distressed Communities Index. This takes a host of it's 7 different metrics. It's attained from the American Community Survey. And higher numbers of DCI are more distressed communities. It's by a 5-digit zip code. Think fewer high school diplomas, more vacant homes, higher unemployment rates, poverty levels, lower business growth rates. And so here we used our state data and show that even more so than female sex, we see diverging curves in terms of use of multi-arterial grafting between patients that come from communities with high distress versus low distress. It's actually pretty impressive. So it's a 30% decrease in the risk of MAG for every 10-point increase in DCI. And it's out of 100. So there are dramatic differences between the highest distressed communities and the lowest distressed communities. That's probably an access problem. However, we don't have any way to fundamentally understand what is leading to that difference. We don't know if it's a community level effect, a patient level effect, a hospital level effect, all of the above. These patients from distressed communities come in with more comorbidities, higher acuity, worse coronary disease. They have higher mortality after CABG. So everything essentially is different. However, in some, it is a huge difference in receipt of multi-arterial grafting. When I was back in Virginia, we looked at race. It's not really been done well at a national level. But what we found was that there had been a gap in Lima use, and that has disappeared. And other process-based aspects of CABG care are roughly similar. In fact, discharge with a beta blocker is higher among Black patients. It's not a process problem. What we did find was there's more incomplete revascularization and fewer arterial grafts for Black patients, and that's consistent over time. In conclusion, we'll leave enough time for questions. Arterial grafts have better patency. Thus, multiple arterial grafting may have long-term benefits, but randomized data has not yet proven this. Arterial graft choice and configuration vary widely. Guidelines do not really reflect the paucity of evidence supporting a clear single choice. And due to wide practice variation with multi-arterial grafting practices and baseline risk and anatomy differences by patient sex, socioeconomic status, and race, there are disparities in receipt of multi-arterial grafting that may impact long-term benefits of CABG for at-risk populations. Thank you, and happy to take any questions.
Thank you, Robert. Excellent presentation and very informative. So I'll start with a question, and then we'll go to the audience. You mentioned that one of the limitations to multi-arterial grafting is the evidence, right? So, yeah. And we're working on that. Let's say the evidence in a few months, a year, becomes more robust. How do we work with the implementation? Because I think you alluded to not every surgeon may have the expertise or the training to do that. How do we change that? Is there a possibility?
Yeah. So there are real barriers to increasing multi-arterial grafting. It is more technically complex. The operations take longer, and there's a learning curve. There's a volume curve, and in a specialty that is so critically reviewed for outcomes, there is a very high barrier to surgeons willing to do something that will decrease reimbursement and increase risk. And so essentially what we've done in our state is a model for other programs, which is recognize that you think it's important and worth doing, and then as a group work together to overcome those barriers. So the state developed guidelines for radial artery use so that practice variation would decrease and standardization would allow programs to implement these guidelines in a way that was evidence-based, and then review the data. You got to look at the outcomes and the results. If you don't push yourself and say, why was our radial use so low this month or next month or whatever it is, you're not going to make any meaningful change. You got to look at the numbers.
I have a question from the virtual audience. This is from John Haft, and he has two questions, but only one has come so far. So can you comment on financial incentive or disincentive for multi-arterial grafting?
Well, so, there is a strong disincentive from a hospital perspective. So these cases, I can't speak for everyone because we don't really have good published data from STS, for example, on time. I think they conveniently leave that out. But for me, it takes at least an hour longer. And I can do 2 standard 3-vessel CABGs with vein and have the staff out when they're supposed to be out at like 6:30 and not pay for overtime and consistently get 2 cases done. That is not the case with multi-arterial grafting. Especially total arterial grafting, if I'm doing a REMA and a radial, it adds a long time. Doing 2 cases means you're done at midnight, and that means a ton of overtime. We just reviewed overtime hours here, and it's an astronomical cost to the hospital. In terms of incentives for the surgeon, it's about 1 RVU, so $70. It's not appropriate for the amount of extra effort, risk, and time that goes into it. You're not going to do that for a financial benefit. You're going to do it because it's right, which means we need the data to prove that that's true.
John has a second question. Acknowledge the presence of Dr. Prager, or his ghost, who created our state collaborative approach and the resultant 3-fold higher use of MAG in the state of Michigan versus the rest of the country. Patients get better CABGs in our state compared to the rest of the country. So thank you, Dr. Prager.
Dr. Prager's impact has been enormous. The number of lives that he's impacted across the state should not be understated.
I have another question from Nicole Valley. Does DAPT really improve vein graft patency? How aggressive should we be about continuing it for a year post-op?
So we've reviewed this data a number of times, and there are essentially 2 scenarios where DAPT is well supported. Acute coronary syndrome, so that's sort of regardless of what treatment they get, and so that guideline is for a year. And then off-pump CABG. It's only really effective in the first sort of month, and we know that off-pump has a higher rate of vein graft failure and incomplete revascularization. And so maybe the quality of the anastomoses are not quite as good. Therefore, DAPT may have improved patency rates for off-pump patients. Everything else is completely useless data, in my opinion.
Dr. Eagle?
Thanks. That's great talk, and it's nice to have our faculty continuing to lead the state in now analyzing the data that we have and learning from it. I have 2 questions. One of them is, Do you have an age cutoff where when they're below that age, you really try harder for multi-arterial grafting?
So what I would say is that this data, having read it now hundreds of times, I've essentially come away with the concept that arterial grafts are probably just better. So from training, I've completely flipped how I think about CABG. I now start from a total arterial default and work backwards. Why should I not use the REMA? Why should I not use the radial? What configurations can I do or not do in order to get there? And it really doesn't matter the age. What the STS data suggests is that there may not be a benefit, survival benefit in certain categories, but it's not harmful. And so if the REMA is a much better conduit, then we should be using it rather than tiny vein with lots of varicosities that's going to fail. That's not a CABG that's going to help an 80-year-old. The REMA may not provide a survival advantage compared to good vein, but you really got to, if you start from, I want to do total arterial because it's probably the best conduit and work backwards, I think that's how here we have really improved our multi-arterial grafting rate.
And the second question then would be more diffuse disease diabetic or in women with smaller vessels. Are you pushing harder for the arterial model there, or they're all the same?
Well, we don't have the data to say. I have, in this endeavor to increase the use of multiple arterial grafting, I have also paired that with transit time flow measurements. And the numbers are really surprising. The arterial grafts tend to have much lower resistances than the vein grafts, but that doesn't necessarily change the amount of flow. And the diffuse disease is a whole separate problem. And I'm not sure it influences whether we should be putting different types of conduit on there. Now, sometimes for young patients who I think might need repeat procedures in the future, say a 39-year-old who I just saw in clinic might need PCI in the future and then might need redo CABG in the future. Sometimes, a whole separate topic is lifetime management of coronary disease for patients with really bad problems. But I don't necessarily want to use all of the arterial conduit in the first go. And so, that is the only situation where I would kind of think about holding back. But I have found good results with arterial conduit to pretty crummy targets.
Thank you.
Yeah.
Any other questions? I'm going to end up with two praises here. One is from Dr. Dyke. Kudos to all the cardiovascular surgeons at Michigan Medicine, and I think I doubled down on that. I think we have an excellent group of cardiac surgeons, and we're very lucky. We as cardiologists and the patients as well. And also Dr. Prager says, Dr. Hawkins, superb presentation. Thank you. Yes, the host is alive, Dr. Haft. And it took the entire state to get to where we are. So thanks, everybody. And again, I'm going to double down on that. I think we are very lucky to have the multi-collaboration in the state that we have at the state of Michigan. So thank you, everybody.
And
thank you.
Thank you, Dr. Prager.